Looks like we're live. Get it started right. What's up, Nackie?
What's up?
You doing all right?
I'm doing okay. It's
I
just
heard
what a
words.
coincidence. It's Koviki talk.
It is that time. Good evening, everybody. Welcome to Koviki Talk. Koviki Talk is a 21 episode podcast series where we talk about COVID-19 from the Pacific Islander perspective. So our guests, ourselves, our topics are all COVID-19, and they are all from our own perspective. So it's going to be Pacific Islanders talking about how this pandemic affects us as a people. So today we have one of our returning stars. Nackie, you want to introduce one of our guests today?
Yeah, we have back to Koviki Talk. Dr. Raynald Samoa is a clinical research endocrinologist. He received his medical degree from the University of Washington. He also did his adult endocrinology fellowship at the Los Angeles County University of Southern California and his pediatric endocrinology fellowship at the Children's Hospital, Los Angeles. Dr. Samoa is the clinical lead for the National Pacific Islander COVID-19 response team and is currently an assistant clinical professor at the City of Hope Medical Center in Duarte, California. Welcome, Dr. Samoa.
Thanks for having me.
And our first time guest also with us this evening, Keni Lasitani, is a fourth-year Tongan medical student at the University of California, San Diego School of Medicine. He is interested in liver disease in Native Hawaiian and Pacific Islander communities and plans to pursue a residency in internal medicine, followed by a fellowship in hepatology. He is also a member of Polynesians in Medicine. Polynesians in Medicine is a national group of Polynesian medical students that strives to increase NHPI representation in the medical field. He is a community outreach coordinator at UC San Diego's Antiviral Research Center as part of the COVID-19 Prevention Network and works to educate NHPI communities on COVID-19 vaccine clinical trials, specifically Janssen and AstraZeneca. Welcome, Keni.
Hi, thank you, Carl.
Well, we have a long timer and a first timer on the show today. I think Dr. Samoa definitely holds the record for being on the show, and it's always good to get information directly from the horse's mouth, so to speak. So we've got to get good information, and that's really one of the goals of the podcast, is to get timely information from the people in the know. So not like getting our information from Facebook, not basing our decisions on a vaccine on our friends' opinions on Facebook, but actually getting the information from medical students, doctors, scientists, any of the people that are going to give us good information. So I think that maybe we'll just kind of talk to, maybe Keni can kick it off and kind of give us an idea of what's important in your world right now before we get to, we have some set questions, but what's going on in the mind of a Pacific Islander medical student?
Oh, a lot. Just trying to keep up. I'm actually currently taking a year off to do research, which is why I was hired to be a community outreach coordinator with the Antiviral Research Center. But yeah, I think that's it. And working with the Polynesians in Medicine group, always trying to look out for our community and make sure that we provide mentorship to, high school students and college students wherever we can.
Was the medical profession, was that something that, like a 10-year-old you was really interested in, or is that something that kind of developed as you grew?
Yeah, no, that's a good question. I think, when I was actually writing my personal statement for my medical school application, I was doing some reflecting to kind of figure out where that desire stemmed from. And I really couldn't discern whether or not it was my own desire or if it was something my mom has told me since I was born. So I think it might be a combination of mine, but also my mom's.
And born and raised, where are you from?
I was born in New Zealand. My family and I moved to the United States when I was 3 years old. I grew up in Utah. Then we moved to Southern California for junior high and high school. And I've kind of been here since.
It's kind of interesting. We were having the discussion before the show about opinions of what countries have done it right. And we look at New Zealand as a country that has done things right. Is that in your mind when you look at the way that we're handling it, that there may be better ways, or there may be quicker ways to the solution?
Yeah, I think so. Yeah, I've definitely noticed, seen articles circulating about New Zealand and how they're managing COVID cases. They're a lot better than we are here in the United States. So I've definitely started looking for my New Zealand passport to see if I want to go back anytime soon.
Kenny, just a little bit off subject, but are you finding, since you're your fourth year in, are you finding every year there's more PIs in the medical field, or is the number flattening, or is it getting higher?
Yeah, no, that's a good question. I can only speak to UC San Diego because I only know the students here. Although I am interested into looking more about the trends for our NHPI Pacific Islander students matriculating into medical school. But specifically at UCSD, I know of myself, I know of another student who is a second year. And then we actually just welcomed the largest, I guess, cohort of NHPI medical students that UC San Diego has seen this year. And that's was 3 new students, or 4 new students, I believe. Yeah.
That's awesome.
Yeah.
That's awesome. Yay.
Dr. Samoa, is it still one of those with pride moments when you see the up and coming medical students and the future doctors and the future leaders? Does that ever grow old?
No, it never gets old, you know. Um, it's promising to see the future. You know, it's people think that, you know, a doctor can do anything. Like one doctor can do all the specialties, and it's ridiculously false, you know. And so there's so much of medicine that we have not had access to that, you know, Keni might be the first Pacific Islander hepatologist that I'll see, you know, and so this is a beautiful thing, you know, and it's I like to see that it used to all come out of Utah, and then you'd have to hear Utah brag about their numbers. But it's nice to see UCSD and other schools becoming more competitive in regards to Pacific Islander recruitment, and so, you know, COVID-19 has been riding the backs of disparities. And one glaring disparity we have is our representation in the medical field.
True, true, true. We're just going to jump right into questions, and then we'll get to Kenny's slide. From Bobby Dalton Roy. I often hear COVID-19 is not so bad with children. This terrifies me because I know that anyone, including children, can be an asymptomatic vector and infect others who may have very serious symptoms. What talking points do you use to address this with parents and young people?
Yeah, no, I think that's a really good question. I believe the data that we have available now does demonstrate that you know, the severity of disease, I guess, in children is not as severe as those for adults who have more underlying comorbidities. But in terms of transmission, I think that's kind of where we are concerned. You know, children are still able to transmit COVID-19 just as anyone else. So I hopefully that answered the question.
Do you think there's a do you think that there is I don't know, that the issue of asymptomatic spreaders, do you think that with the increasing cases that will be taken more seriously? It really seems like almost a sense of carelessness sometimes with people that I think there's go ahead.
Go ahead.
No, I was just wondering if the uptick in cases right now, if you think that will help bring awareness to the, the young and the healthy and the ones that don't really, that don't have really the extreme effects of the pandemic. There was almost, in my eyes, just in what I've seen, there was almost a sense of carelessness with some of the people that were asymptomatic, or that didn't really have to worry about the disease, so to speak. Do you think that uptick in cases will help bring awareness to the people that are asymptomatic?
Yeah, I mean, I would hope so. I know that we're kind of at a peak for cases, a new peak for cases now. But I mean, when we first started off in March and April, I think the message of asymptomatic people can still carry and transmit what has been a message from the beginning. And so I guess we're at another peak, or a new peak. So I hope that, people take it more seriously. But I don't know.
Yeah, I mean, I agree with Kenny. The truth of the matter is we don't know. And so that's one of the things that plagues us with making gains regarding this pandemic, is our lack of inability to track these types of thoughts and behaviors. And so, they're starting to field this kind of information in the general population and in other larger groups. But because we notoriously get left out of data reports, that our stories hardly ever make it to the forefront, we don't know. And if we depend on sort of the current data sources, we'll never know. And so one of the reasons why we have Koviki Talk, one of the reasons why Kenny and the rest of us have joined response teams and task forces, is because there are many of us that are tired of this. We're tired of being left out. And whether it be diabetes, cancer, and now COVID, this idea of us having any type of say in our healthcare, it's long overdue. And so, the people you mentioned, how it seems somewhat, what'd you call it, Carl? I don't want to misquote you. Disrespectful.
I think there's a sense of almost irresponsibility with some of the some people, I guess I'll just put it that way, that weren't as at risk as other people.
Yeah, it's hard to really say why, and unfortunately, it's that's the entryway, into our communities, is that we are essential workers, and that essential worker age group will transmit it to our vulnerable older generations who are at home. And that younger, especially, young adult group that are essential workers, it kind of goes against culturally what we know. The role of a young adult in a lot of Pacific villages and in Pacific communities is to go and lead, right? Is to go and find fortune and take care of the family. What we're seeing now is this sort of westernized mentality that I go and I get my money, and I just sort of think about my personal space. And this is just sort of a pattern, right? This adopting of the dominant culture, and the farther removal we have from a lot of our roots are predisposing us to disease, And so Nackie and Carl know that this is one of my favorite topics, is our divorcing of our roots, and how it hurts us more than anything.
Yeah, I just wanted to add real quick, like somebody literally said this to me today, that they went to the grocery store all masked up and everything, and seen an elder, an aunt, and it took everything in her to not, hug and kiss and say hello. Like she said, I struggled so hard with it because I felt like I was being disrespectful. And then I was like, but you literally could be possibly saving her life by not hugging or kissing. And I think that's with all of us, is the struggle of disrespect, and really what is disrespectful if you would have hugged and kissed, because you're possibly risking a life. So that really, I was like, dang, I never thought of that, but it is it's a struggle for us not to hug and kiss the elders. So thought I'd just mention that. But Keni, we want to get to your slides because we want to get all the good information within this hour and make sure that people get their questions answered. So let's go.
Awesome. Yeah, at any point, feel free to jump in, ask questions, or ask for clarification. Just kind of the overview of the presentation that I wanted to give today was I wanted to talk about some clinical trials, specifically Janssen or Johnson & Johnson and AstraZeneca, and how to enroll in them. But I also wanted to talk about, like Dr. Samoa had already started discussing, the impact that it's been having specifically on our Pacific Islander community. So with that being said, I first want to just, preface my presentation by saying that I'm not here to convince anyone to join a clinical trial necessarily, but my hope is to present, everyone with enough information so that you can make a more informed decision about whether or not enrolling in a clinical trial is something that you want to do. I know particularly right now, there's a shared sentiment of mistrust amongst a lot of communities of color, including our own. Specifically towards clinical trials, vaccines, the healthcare system. It's rooted in historical and continued and medical racism. And so this is a very valid consent, and it's important that these pharmaceutical companies hear us and our concerns. But with that being said, I just want to ensure that we move forward with caution and that we press these companies to be transparent with the data for their clinical studies. So all in all, I'm here to give information. I'm not necessarily recommending any of these trials. So next slide, Tavai, please. So first off, I just wanted to set the stage for why COVID-19 vaccine clinical trials are so important and why it's so important that we're looking for something to prevent this, because it is impacting our communities. Next slide. I wanted to first make a comment on data disaggregation. I'm very appreciative of Auntie Esther and Carla for the talk that they gave last episode. I think it was very timely and it ties in really well with my talk today. So just kind of as a general overview, why data disaggregation is so important. So the way it works, we conduct research in different surveys, and we take these results to decide how resources are going to be distributed on a federal level and at state and local levels in order to develop different policies, programs, and interventions to address social, economic, and health concerns for different communities. And so when our data is aggregated with Asian Americans, our communities are overlooked. We're understudied and we're underserved. And I think it'd be worth it. Auntie Esther, I think last week, was talking about the Obama White House archive and the document in there regarding the revisions made to what the standard was. But it's this the bullet point that I'm discussing. I think it'd be worthwhile to share that again for everyone to know, because it's important. It's an important tool that we have to use to remind people why data disaggregation is so important. Federal agencies are following this recommendation, the census, for example. And so I think, researchers should follow suit because that's the only way our communities are going to be seen. So it's important that we disaggregate data so that our communities are visible. Next slide. So the data that I'll be sharing in the next couple of slides was taken from the Native Hawaiian and Pacific Islander COVID-19 Data Policy Lab, which Carla is a part of. So shout out to her and the COVID-19 Data Policy Lab. Honestly, the work that they do there is very invaluable, and we would not understand how our community is being affected without their work. So thank you to Carla and the data policy team.
Yeah.
So these are the current reported COVID cases and deaths for our community as of December 3rd, 2020. So 30,832 reported cases and 367 reported deaths. And as you can see, compared to November 25th, in just 1 week, our cases have increased by 1,599 and by 11. Next slide, please. Sometimes it can be difficult to really understand like what these numbers mean when you just read the cases and like the number of deaths from COVID. So just to kind of give those numbers in the previous slide a little bit more context. Here you can see that in 9 different states that disaggregate data for our communities, not only are the case rates uptrending for our communities or increasing, but we have higher case rates than any other race or ethnicity. So obviously this is something that's very concerning. Next slide. So this is the last data. I know data is hard to look at, interpret, but just on this last slide, you can see that there's 21 states currently that disaggregate their data for NHPIs. And this shows the rates and the ranking of the rates compared to other race and ethnicities. So our communities have the highest number of COVID-19 confirmed cases out of any racial or ethnic group in 15 of these 21 states. And in the other 6 states that were not ranked as the highest, were either second or close to second. And then on the right side of this chart, you can see that in 9 of the 16 states reporting disaggregated health data, we have the highest death rates of any racial or ethnic group. So once again, thank you to the National Pacific Islander COVID response team, the work that they're doing to push to get this data disaggregated. Otherwise, we wouldn't be able to see it this way. And so when we're thinking about some of the underlying reasons for why there's higher case numbers in our communities, as Dr. Samoa mentioned, we are essential workers, we're frontline workers. So obviously we're more at risk or higher risk for exposure to COVID-19. In addition, we live in multi-generational households. It's not just one family, and the communities that we live in are usually a lot more dense. So that also increases the risk exposure. And when we're thinking about the death rate and why it's so high, we know that comorbidities like asthma, obesity, diabetes, heart disease, smoking, are very prevalent in our communities, which puts us at a higher risk for severe COVID-19 disease and higher risk for death, unfortunately. And the other, I think, underlying reason might be because of delayed medical care. Both of my parents, they have comorbidities. My mom, she works for, and our frontline workers. My mom works for the United States Postal Service as a mail sorter, and my dad works as a maintenance worker at a long-term care facility. And they both live in Utah, where the case rate and the death rate is just extremely high. So obviously looking at these numbers is very concerning for me personally. And I know that this is probably the same case for a lot of our families, unfortunately. So it's important that we continue to wear masks, that we continue to social distance, and participate in these clinical trials, as I'll get into in the next couple slides. So next slide.
Does the NHPI medical community see this as 2 issues of access to medical care and those kind of things, as well as the comorbidities that we have, high blood pressure, diabetes, obesity, in terms of prevention for whatever next virus or next illness comes along? Is it thought of in that manner, that there's really not 2, there's probably more than 1, but that there's an issue with lifestyle and with habits?
Oh, absolutely. This isn't a lot of the players in this game are the same players that have affected our communities for heart disease, the same players that have affected our communities for liver disease, like hepatitis B, like you mentioned, Carl, access to healthcare, whether or not we have insurance, or even trust doctors or have doctors that look like us that we can see. Obviously, we prioritize going to work over going to see a doctor because we care about providing for our families. Right. So it's the same underlying reasons that affect our communities for other diseases that are also affecting us for COVID-19, as you can see in these numbers.
These numbers are crazy high.
They are.
Crazy
and
high.
what I, it's crazy that we wouldn't know this unless our data was disaggregated.
Right.
If it was aggregated, our rates would be hidden.
Yeah.
We would be characterized as having lower case rates and lower death rates, or closer to those of Asian Americans. So it's crucial. Honestly, I can't emphasize enough how important having disaggregated data is.
Yeah.
Yeah,
Like,
it was a little bit into the pandemic when these flags started coming up, because I remember the numbers and, wear a mask, stay home, wash your hands, those kind of things.
mhm.
Those were being pushed, but it was several months into the pandemic when people really started looking at it and going, whoa, like there's obviously a big problem with the pandemic, but there's a specific problem with Native Hawaiian Pacific Islander people. So we wouldn't know that, like to your point, unless we had the data that showed
Yeah,
it.
no,
Right.
absolutely.
And this is just data from 4 days ago,
Yeah.
I mean, it's 4 days ago. So it's crazy, crazy, crazy high. These numbers, I just can't believe.
Yeah. If we could share the dashboard link again in the chat for people to reference, that's where all of this information was taken from, and it's available for anyone to see. And it's updated on a daily basis, I believe, the numbers.
Crazy.
Next slide, please.
Question in the chat.
Someone is asking, what's going on in Arkansas, Iowa, Illinois, Louisiana? The case rate appears way higher than states with larger population of NHPIs. It's a good question. Louisa, from Louisa.
Yeah, no, that is a great question.
Is it because I'm just guessing, are we reporting more in those states, or more PIs taking the test? I know that there's a huge Marshall Island community in Arkansas.
So we have the COFA communities have migrated to the South and the Midwest, and they support a lot of agricultural industries in those areas. And so they're at high risk because those industries have shown to have huge outbreaks. And so you have the combination of being in a really high industry with really poor access.
Mm.
You have communities that have just recently, I think in 2017, a lot of the Medi-Cal restrictions started to happen for COFA communities. And so you're starting to see these outbreaks happen in communities that are disenfranchised the most. And so that's why you're seeing those numbers in those areas. What's really scary is those are state numbers, right? States are big, they're large. Just because you know that there's a high rate in the state doesn't mean you can do anything about it. You need county data. You need zip code data to try to figure out how you're going to help those communities. And those counties are not reporting disaggregated data yet. So, one of the things that we're trying to do is to engage those communities in those places that don't have coalitions, that don't have like a group to go and advocate public health departments to start pushing out data so that they can get their numbers. Because the thing about it is the numbers drive the game. When the data informs people how much money you spend on a particular community during the outbreak. And if you don't have any county data, it's hard to justify focusing on those communities.
Right. That's crazy. It's so important. And also when you take your test, I noticed, because I got tested recently, they ask you what your ethnicity, what your race is, and I make sure I'm like Native Hawaiian Pacific Islander. They're like, oh, I never had that one before. Well, check that box, lady.
Yeah, there's data is very complex. There are places where you can identify as NHPI or you can state your ethnicity.
Right.
In some of these places that don't know that that one is a category of another, it's an either or.
Mm.
So you'll be listed as Marshallese and not count under the NHPI box. So there's all these nuances of data that requires education for everyone to get through. Hawaii has ethnicity data, and there are some counties, I think, in the Northwest that are producing ethnicity data, which is subtypes. So in Hawaii, they're able to break out Samoan, Marshallese, Chuukese, Tongan. And like I said, this is also the case in some of the Northwest counties. And so in a lot of those counties, you're starting to see where there's the predominance of cases are from Kofa communities or Micronesian communities, such as the Marshallese. And sometimes you'll see that the highest risk group is Samoan. And so you can see how that type of information is extremely helpful when you're trying to target and you're trying to improve the numbers.
Absolutely. So I've kind of outlined the need. Obviously, there's a need. Our community is being impacted. And so what I wanted to discuss moving forward was kind of the response from our community, in addition to the response on a federal level, referring to the clinical trials. Next slide. So from a community perspective, there's been an unprecedented response from our community leaders and advocates like Dr. Samoa himself, who have mobilized to establish, the National Pacific Islander COVID-19 response team. They are the ones who are pushing for policy changes so that we can have data disaggregation, so that we know exactly which zip codes, which communities of ours are being impacted the most, so that we can ensure that the funding is being allocated appropriately. So I think, I'm super grateful to them for taking the call to action. And I think that overall our community has responded to this really well. It's the local, state, and the federal governments that need to cooperate with us. But I think that, yeah, we are doing a great job so far. Next slide. I think the next couple slides, Dr. Samoa and Dr. Hatia Young, on one of your other Koviki Talk episodes, they kind of discussed Operation Warp Speed, the process of clinical trials, and so forth and so on. And so I don't want to spend too much time on these, and I want to get to the clinical trial specifically, because I'm sure that's where most people have questions. Yeah. But essentially, I think the point that I just wanted to make here was warp speed doesn't mean skip steps. I know that safety is a huge concern. But I can assure you that steps are not being skipped. It's just an accelerated process. Next slide. So this is just a general overview of the different clinical trial phases and what the main focus for each phase is. So as you can see in phase 1, the main question is the vaccine safe? It's a smaller group of volunteers, and so their main concern is if it causes any severe reactions. And they continue to phase 2, they look at the immune response to the vaccine. Phase 3, they start looking at whether or not the vaccine, what it was designed to do, which is protection, transmission, and severe disease as well. And so we're currently in phase 3, but throughout each of these 3 phases, we are monitoring safety. And each of these studies has a safety protocol in place, so that when a severe reaction or adverse event does occur, the study is paused. And then an independent, meaning a safety board that isn't associated with the pharmaceutical company that is conducting the specific clinical trial, conducts an investigation to see whether or not the vaccine in question is still safe enough to move forward with testing. I think the main point is safety is being monitored in all these different phases in the clinical trials. Next slide. So this is how, I guess, an overview of how a vaccine is produced. Starts off with some basic biology research, and then moves through the different phases. We're currently in step 3 and 4. 4 referring to like Pfizer, Moderna, who will be filing for emergency use authorization soon. So yeah, and there's a general outline as well for how long it normally takes. So for clinical trials, you can see that it normally takes up to 5 years. But because, as I mentioned, there's an unprecedented need, we need an unprecedented response. So we're accelerating it, and we anticipate that it'll be about 1.5 years that these clinical trials will be conducted over.
This question is for either Keni or Dr. Samoa. Is there a common misperception of the vaccine production process or the clinical trials that you hear being spoken out there? I hear, oh, they skipped the animal testing phase. I've heard a bunch of different things that are out there on social media, disinformation, so to speak. But is there a common misperception of this that you guys hear, or any one or two that you hear often?
Yeah, no, absolutely. Not just from our own community members, just the public at large, with good reason too. Everyone wants to ensure that this vaccine is being produced in a safe manner, and so they want to ensure that each of these steps is being followed. Where we get into, oh, they skipped this step and they skipped that step. I mean, I haven't seen I haven't seen anything from my end, and in the work that I do, or articles that have shown that steps have been skipped. They're definitely following them. It's just an accelerated process.
Yeah, and a lot of the steps have been combined. Like research and preclinical preparation were happening almost simultaneously.
Absolutely.
So that's why they've been only doing this for 10 months, and yet you look at it, it's 12 months. No, it's because a lot of these steps were being done in coordination.
Yeah, that was specifically the animal phase. I saw that on Facebook. I don't know why I pay attention, but it said, oh, they skipped the animal trials. And it literally took one Google search to see that they ran those concurrently with phase 1. But there's so much disinformation, I guess, out there that I didn't know if there was a common theme running through that you saw. I appreciate it.
Yeah, a lot of times there's a little bit of a hiccup in getting these studies up and approved, but the approval process for a lot of these animal studies and phase 1, they were accelerated. A lot of time it's the review process that's what takes time, and those were all pretty, accelerated at light speed.
Absolutely. Next slide, please. So the main objectives or the questions that we're looking at for each of these different studies is, 1, is it safe to give to people? And 2, is the vaccine reducing severity and frequency of COVID-19 illness? So these are kind of the main questions that we're looking at in conducting these studies. Next slide, please. You can actually just, next 2 slides. Yeah, next one. So I want to just spend a little bit of time talking specifically about the Janssen and AstraZeneca clinical trials. Those are the ones that I help oversee here in San Diego for outreach and enrollment. So the Janssen, or Johnson & Johnson, Janssen I think is the name of the pharmaceutical company, but people know it as Johnson & Johnson. It's in phase 3, as I mentioned. It's randomized, double-blinded. They're trying to enroll 60,000 people nationally. And I think most people kind of understand how the vaccine is being developed, but essentially it's not they're not giving you coronavirus. They are only giving genetic material that allows your body to recognize the spike protein, illustrated there in the top right, so that your body can recognize when you're exposed and elicit an immune response. And it's only that small particle, that small protein that they're introducing, not the virus itself. So it's impossible to get the COVID-19 from any of these vaccines. In terms of the injection schedule, so Pfizer, I believe, and Moderna and AstraZeneca are 2-dose vaccines, whereas Johnson & Johnson is just 1 single injection, or currently I think there's some talk about doing 2 doses as well. But currently it's just 1 single injection. And the randomization ratio is 1-to-1. What that means is that 50% of participants will receive a placebo, which is just salt water, and then the other 50% will receive the study vaccine. Next slide. So for AstraZeneca, also phase 3, trying to enroll 30,000 people. Similar technology and the way that it works to Johnson & Johnson, so I won't go over that. The main difference is their injection schedule, highlighted below. So for their vaccine, they're doing 2 doses given 4 weeks apart. and their randomization ratio is 2-to-1, meaning that your chances of getting their study vaccine is 2 times higher than getting the placebo for their study. And for each of these studies, there is compensation. I think I forgot to mention that in the previous slides. For each of your visits, you receive some compensation for your time, and to pay for transportation and other things just for your time. So that's also, I think, a common question. Next slide, please. So these are the general eligibility requirements. If you're interested in enrolling, you first fill out some information on the COVID Prevention Network Registry website, which I'll share shortly. You'll then be contacted by a clinical research coordinator that's local to you. They'll go over all of the criteria with you to ensure that you can enroll and that you're healthy enough to enroll as well. They'll do physicals during your appointment to ensure that you're healthy as well, that your vitals are okay. And then they'll also go over the informed consent with you, which basically outlines, how the study is going to be conducted, what your rights are as a participant. So you can ask them any questions you want during that time. But it does vary based on the study, their eligibility requirements. But just as a reassurance, you'll be contacted to go over all the eligibility, and they'll let you know whether or not you qualify. Next slide, please.
So there's no age limit, like you can be as young as 18 and as old as.
Yeah, there's no age limit.
Okay.
Yeah, good question.
Because somebody's asking if a 93-year-old can take the elder. I was like, I'm assuming you have to fill out questions and be healthy, right?
Exactly.
Right.
Exactly. We want to make sure that you're healthy, but you will be in contact with someone who will ensure that you're eligible based on your age, your health conditions, so forth and so on.
Awesome.
So I wanted to spend some time on this slide because I know a lot of people have questions about, the Pfizer vaccine coming out soon with the emergency use authorization. So, a lot of people are wondering, why should I even participate? Is it important that we continue to participate in these clinical trials that are still being conducted? So to answer that, the first point would be, so even though, Pfizer and Moderna are going to be filing for EUAs or emergency use authorization shortly, the supply that is going to be available is going to be very, 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 very limited. It's not going to be for everyone in the general public, unfortunately. It's going to be prioritized for healthcare workers and people who work in long-term care facilities. For a lot of people who are like, oh, I just want to wait for the vaccine, it may be a couple months before that even becomes available to you. And so by participating in some of these clinical trials, you have a chance of getting the study vaccine. So on the second point, I think most people are aware, Pfizer and Moderna have come out with their efficacy results, or basically showing the data that their vaccines are working to reduce the severity of COVID-19 disease for people who received it. Their studies also targeted this spike protein that I was talking about. And I believe that all the study vaccines are targeting the same spike protein. So we anticipate that most of these studies are going to have similar, if not better, efficacy compared to Pfizer and Moderna. So with that being said, if you participate in clinical trials that are still being conducted, you have a chance of receiving the vaccine that may or may not be equally efficacious to those of Pfizer and Moderna. Another point would be, so as I mentioned, I think supply is kind of the biggest barrier to widely distributing vaccines to everyone. So if we can get more EUAs for these different vaccines, then we increase the supply. So if Pfizer, Moderna, Johnson & Johnson, AstraZeneca are all able to provide safety data and show that their vaccines are efficacious, then they can all contribute to providing vaccines clearly we have a high demand for vaccines. Also, I know that Pfizer and Moderna specifically, they have made statements about providing the vaccine to people who participated in their study, but who received the placebo. And so we anticipate that for these other clinical trials like Johnson & Johnson, AstraZeneca, and I think there's even some other studies that will be starting soon, they also plan to do the same. So if you participate, then you're kind of also moving your way up the line to get a vaccine if it gets approved for an EUA. And then the last point, I think, is just it's important that that we are represented in these clinical trials, because we need to make sure that these vaccines are safe for our communities. And when I say diverse group of people, we're not only referring to race and ethnicity, but we're referring to age, we're referring to different comorbidities, healthy versus unhealthy. We need to make sure that this vaccine is safe for everyone. And we can't say that, or these companies can't say that, unless our people are participating. So I think those are kind of the big for why it's still important for people to enroll in these clinical trials. Next slide. So if you are interested in enrolling in a clinical study for the COVID-19 vaccine, you can visit Coronavirus Prevention Network. We can share that in the chat, that would be great. And then you would just go to volunteer now and fill out some information. And as I mentioned before, you'll be contacted by someone who will go through the eligibility requirements and informed consent and so forth and so on. And then next slide. So I just wanted to finish off talking about equitable vaccine distribution. This has been an important topic that has been in discussion, and Dr. Samoa had already kind of been mentioning earlier on. So when we're talking about equity, it's different than equality. I think this little picture that I showed kind of illustrates that more clearly. So when a vaccine becomes available, we need to ensure that the communities who don't have access, or the communities who don't speak English, the communities that are being most impacted by COVID-19, have equal opportunity to this vaccine, if that makes sense. So we need to be able to address all these different barriers for our communities to get this vaccine. And that's what we refer to when we mean equitable vaccine distribution, because we may have more obstacles compared to, Caucasians or white people who have insurance, who are more likely to be from a higher socioeconomic status, and obviously are overrepresented, in my opinion, in the medical profession. Next slide. So I know that the COVID Prevention Network has made a statement saying that they are going to establish recommendations for how these EUAs should be distributed in an equitable manner so that those communities who are most impacted receive them first. Next slide. Kind of just a framework that was created by the National Academy of Medicine and Sciences and Engineering for how we should distribute vaccines to ensure that it's distributed in an equitable manner. So you can see here, it's outlined in different phases, but essentially phase one would be like high-risk workers and healthcare facilities and first responders would be the first ones to receive it, and then we'd move down the phases. Next slide. So just some final thoughts and kind of just to wrap up. Interested in enrolling, there's a website again. And then it's so important that we're involved at all levels, not just as participants. I know I was kind of talking about that mainly, but it's important that we are involved at all levels, that we are, doing data disaggregation work, that we're pushing for policy so that our communities receive the things that they need. I know specifically for me, working as an outreach coordinator with the COVID Prevention Network, I've noticed that the data for people in our registry and those who are enrolled in our study are not disaggregated. And that's really disappointing because, as I mentioned before, there's a federal recommendation for federal agencies to disaggregate our data, yet these people still aren't doing it. Mm-hmm. So it's important that anytime we see that our data isn't being disaggregated, that we bring this to awareness and we continue to push that. But if there are any other questions or concerns, feel free to email me, or I guess we could go over some questions now.
Oh, I just had a real quick, and I could be wrong, but can you let me know if I've got this right or wrong? We're looking for the, I'd say people of color more so, right? To participate in this. And
Yeah.
what I think it means is that we need Pacific Islanders to, because what may work for the Hispanic community, if this vaccine works well for the Hispanic community, that if we don't join this, we Pacific Islanders, when the vaccine comes out, it may not work on us because of something, you know, Hispanics have a different gene, I don't know, something different in their being. And so is that right? Like, that's what I'm thinking, is that PIs should volunteer just to know how we react to the vaccine, right?
Absolutely. Yeah, it's so if none of our community members were to participate, and they had data on all the other race ethnicities, they couldn't say that, or that this vaccine is safe for everyone, because we weren't included in these clinical studies, or we didn't participate. So yeah, just as you mentioned, Nackie, those are the reasons why.
Okay, awesome. And is there anything negative that, like, can someone die from this, or, which I'm sure people are worried about, and I've heard this over and over again, is that people are afraid. What, like, can something, I mean, I'm sure, like, I don't know, they're injecting you with stuff. Can you die? What can happen?
Yeah, no, it's a great question. A lot of the technology that's being used for these vaccines, as I mentioned, is technology that has been used in vaccines for like Ebola or other viruses that have shown to be safe to be used. As of now, no one has died from receiving the vaccine. I think they still have to report. I think they have to report deaths for people who have received the vaccine and those who received the placebo. And as far as I know, there have been no deaths from that.
Awesome. And then Louisa is asking, do you have to live in a specific state or city to participate in the clinical trials, or is it happening everywhere?
Yeah, no, it's definitely happening everywhere. If you visit the coronavirus prevention network.org mentioned there, they'll ask you for your zip code. That way your information is kind of forwarded to where you live, and they'll contact you there.
Awesome.
Yeah, you can, if Tawari, can somebody drop that in the chat?
And then, someone is asking on Facebook, is there any medicine to counteract any effects of the vaccine? Have they thought that far ahead, right?
Oh, so I may not be understanding their question.
Like, if someone gets the vaccine and they get a side effect, or is there a medicine to?
Yeah. So the kind of side effects from the vaccine are side effects that you would expect from any other vaccine. So you'll experience some soreness at the site of injection. Some people may experience some like body aches, fatigue, or you might even have a little bit of a fever. But those are kind of the main ones and they resolve on their own. Awesome. But because you are enrolled in these clinical studies, you're followed very close by your clinical research coordinator. There's ways that you report the symptoms that you're experiencing. You're contacted by a provider on the study to ensure that you're taken care of, and that your symptoms resolve, whatever they are. But the symptoms that are experienced have been very mild, from what's being reported.
Awesome, thank you.
Looks like there's a question in the Q&A part.
Yeah. Are NHPIs and mixed with other large demographic groups such as Latinx, African American, or any of the Asian American groups counted as NHPI as well?
So are they asking if like you can market more than one, like race ethnicity, like if you're multiracial?
Right.
Yeah, that's actually a good question. If I'm understanding correctly, when you are signing up, you'll notice that you can check off whatever boxes apply to you. So some of this data does overlap. Yeah.
Yeah, but most times they go to the larger group.
Okay.
Oh, really?
So it depends on how it's being looked at per state. but many times in if you have like multi-box, it'll go to the larger group.
Oh,
You
wow.
count it as a larger group, which is problematic for a lot of Pacific Islanders, because a large number of Pacific Islanders identify as mixed.
Yeah.
So you get a lot of hidden data.
So would you recommend that we would check off, like, say, if I'm half, you know, Caucasian,
Mhm.
would you
would recommend
recommend that what's that?
I would recommend they fix it. I would
Yeah.
recommend
I know, but right now,
right now.
we should check the PI box, shouldn't we?
I don't know. Well, so it's kind of a identity question at that point.
Mhm.
That's
You have to
true.
choose, which no one should be made to choose.
Right,
No.
right.
So, you know, fill out with your heart which one you think is the best.
That's true.
But you know, the truth of the matter is, it doesn't matter. You know, like, people are going to fill out what they believe they are, and then the government's going to tell you what you'll be counted
Right,
at.
right.
I don't know if that's a great way to go.
Yeah, that's not. That's not, but okay. Okay, there you go. Great information. Thank you so much. Do we have any other questions in there? Oh, we're so good. Look at you guys. And we're on the money too. Our hour just went by so quick. Did you have something you want to get out, Dr. Samoa?
Just real quick, you know, Kenny, thank you so much for that presentation. I think we met like years ago.
Yeah.
Yeah, I remember. So it warms me to no end to watch Kenny, Carla, Karina, that young Pacific Islanders are starting to develop capacity to promote change in our community, you know. And so you know, before, let's just say the plan used to be don't die.
Right,
So, you
right.
know, I'm very happy to see that we have a different contingency plan now.
Oh my God, it's awesome.
So
It's amazing.
you know, yeah. And so thank you, Kenny, so much for bringing hope with your presentation.
Of course. Thank you. We're just following in your guys' footsteps.
Oh my gosh. Thank you so much, Kenny. That was great information. And if we can have the copy of your slides so we can
Yeah.
hand it out to everyone that's logged in.
Kenny, say hi to Happy.
Oh yeah, we'll do.
Yeah. She's a champion.
Oh,
Her
absolutely.
and Mona. There's so many champions in San Diego. So please give them my best.
Most definitely.
Yay. Well, our hour went by really quick and we're so grateful for the both of you for your time. Kenny, thank you so much for the great slides that we're going to share with everyone on that's logged in, and we'll put links on Facebook on our page and the Pacific Islander COVID-19 response teams page. We appreciate you. We appreciate you, Dr. Samoa.
One quick thing. Don't forget to fill out the survey, the NHPI survey.
Yes.
Yes,
If you're
don't
given the
forget to
survey,
fill out the survey.
please fill that out.
Yes, thank you
Go
so
ahead,
much. We're here every Monday at 5 o'clock. You probably will see Kenny's face on the next 10 flyers to get people to come and watch. He might not be on the show, but his face will be on the flyer.
I'll be in the audience.
Yes, thank you so much. Again, this was brought to you by Pacific Islander Center of Primary Care Excellence, PCOPC. You will see us again next Monday at 5 p.m. Thank you so much for joining us. Have a good evening.
Thank you both.